Thank you. One of the things you said that you have a good buy-in on patients in a medical home, and that you have like what 7,500 plus in the state, and how many are actually in it?
We look at the primary care population of physicians. There are about 1,400 primary care doctors enrolled in Medicaid. To be in the program, you have to have at least 300 Medicaid patients.
Okay.
So the practices that have 300 Medicaid patients, we probably have 75-80% of them.
Okay. But what is that number? Like,
How many doctors? We have about 800 doctors
that are in it.
Yes.
Okay. Because one of the things that, have you looked at the requirement for the 300? Because I've talked to people that would like to participate, but they can't because they don't need the 300. Right?
Yes, and as we move forward, especially with more payers getting involved, we will be adjusting those thresholds. We would like to expand the program. That's correct.
Okay, so that was one of my questions. The other thing is, I've heard a lot of the negative on the episodes, so I'm going to separate the two. I think they should be separated because I think one is punitive. I think episodes are punitive, and I think patient-centered is not. So how much, and you have projections here, correct? These are projected savings. How much have we collected and paid out? And I think there's also probably money on the books that may be sharing savings, but that had not been collected. So do you have those numbers?
You're talking about episodes, right?
Yes, I'm talking about episodes.
And we'll be happy to share the specifics year on year in terms of what we have received in terms of where providers, for example, have had risk sharing, to your point, in terms of where they've had to pay back money to the state versus gain sharing or shared savings where we've actually shared money with them. We'll be happy to provide that to the committee. But I think to your point,
I've asked that. I've asked for that information many times.
well, I know we've shared it in the past, and unfortunately we didn't have it with us today, but like I said, we'll be happy to send that over to the task force. But I know we provided that at previous meetings, but we'll be happy to do that again.
Well, I think those numbers are really important. I want to see actual money because, and I think my next question will be for the Stephen Group about how much we've spent on implementation design because you said it requires a lot of data crunching.
A question, a comment is punitive. When the episodes were designed at baseline, we set it up that 80% of providers would be revenue neutral or winners. And that would be a baseline. So everybody could potentially improve. So that we could run a program that would be successful if there were no one sharing costs. But we designed it specifically that most clinicians would be revenue neutral or winners in terms of shared savings.
Right. I think just to put a finer point on that, when you look at these, when you look at the direct savings to date that you're seeing on these pages and that we've talked about in previous settings, that's really based on the overall provider behavior Dr. Boland was saying in terms of we projected based on how we built the episodes that we would see at least a 5% improvement in behavior year on year. So really, the savings to the state are not as a result of any money that providers are going to have to pay back. Really, that's our hope is that's Dr. Boland's point. That's a smaller share in terms of really there shouldn't be that many providers paying money back to the state. It really should be providers who are changing their behavior. In which case, then either if they're already doing what they should have been doing, then that's great. That means there's no impact in terms of on their particular practice. But for those who really have said, hey, I see some opportunity here and I want to be able to take advantage of that, then that's where the shared savings or the gain sharing comes in. But we'll be happy to provide those specific numbers here.
And the goal of the program was to reduce future costs and cost growth rather than actually pull back money out of the healthcare system from baseline. So if we could do that, great. But the goal was to reduce future growth.